Okay. So,
If he has trouble, we have skills for him.
that's right. Good. There we go. Okay. So, I'd like to introduce Alan Fruzzetti, who will talk on dialectical behavioral therapy, and he's the research director of NEA.BPD, and he's associate professor and director of the dialectical behavioral therapy program at the University of Nevada at Reno. But again, we're running about 15 minutes late. We'll still have the break, and we'll still have an hour for the panel. So there's a lot more to come, even if it feels like you've only just had a little taste or a tease of.
Okay, thanks very much. Good morning, everybody. It's a pleasure to be here. And particular thanks to Dr. Hoffman and Dr. Silk for putting this morning together. I think it'll be fun to compare and contrast a little bit about these treatments, which, although I think they do have some things in common, actually have some very important differences. So I want to talk a little bit about DBT. So I put all of DBT on one slide. I don't just have one slide, but I decided I'd start here because I want to orient folks to the treatment. And then I'm going to talk about the treatment and a little bit about the case of Jane that you've got in front of you. The essence of DBT, I guess this is not quite a David Letterman list, but it's something like that. But first of all, that I think that the way we understand problems is, of course, different than as Frank or as Dr. Young will talk about in a little bit. It's a little bit different. In DBT, we understand borderline personality disorder, indeed a whole set of disorders that co-occur with borderline personality disorder, as disorders of emotion dysregulation. So we see emotion dysregulation as the core, not a symptom. We actually don't see symptoms in DBT. We see behaviors. We see things people do. People think, people feel, people act, and emotion dysregulation is the core. We have a transactional model for how these kinds of problems develop, which I'll highlight in a minute. And one thing we do in DBT is pay particular attention to the different problems that people have. And we address more severe problems first, problems of stability first and safety, and then move on to problems that have more to do with unhappiness and misery and despair. And then we go on to ordinary problems of living. DBT is also a little bit different because it has multiple functions and components, which I'll highlight. Actually, 5 different parts to DBT. Although from the patient's perspective, there are 2. There's usually an individual therapy and a group skill training, but they're actually different functions that we're achieving. In addition, there's a particular set of skills that the therapist has to learn. The therapist has to learn the same skills in order to provide the treatment as we're trying to help clients and patients learn. So this in particular has to do with mindfulness, acceptance, and validation, and in particular treating patients as equal human beings. This actually, although I'm sure that no therapist would disagree to say that, gee, we don't treat our patients as equal human beings, but I think that this has implications that are different in DBT than they are in other therapies. We also have an inductive understanding of behavior and behavior problems. And when I use, by the way, when I use the word behavior, I include anything a person does. We're feeling, we're thinking, we're acting. Those are all behaviors from a DBT perspective, and there's some technical reasons why we do that, but we try to understand our patients inductively by looking at specific examples of when they have problems in living and actually trying to build from specific examples. We use skills, psychological skills, things like mindfulness and emotion regulation skills, things that we actually, many people do quite every day, dozens, maybe even hundreds of times a day, that we don't necessarily think of skills, but we do them. In the same way that if you drive a car, you don't think of that as a skill, but it sure is skillful if you don't drive a car. It's a lot involved in learning that. If you've never learned how to drive, there are a lot of parts. On the other hand, if you've been doing it for a while, you don't think about putting your foot in the clutch. So we think about psychological skills quite the same way. Once you're good at them, you may not realize you're being skillful, but in fact, you probably are being very skillful. And also the D in DBT, the dialectics, is this synthesis of opposites, this synthesis of polarizations, and in particular, acceptance and change, that we try to do both, acceptance and change, even though they seem to be, at first glance, opposite things. DBT also includes a consultation team where we treat the therapist, that we actually are trying to keep ourselves in balance. And DBT also is based on current, whatever we know from behavioral, cognitive, and emotion science. So DBT is actually not a static treatment, but an always evolving treatment because it's always including new things that we learn about human behavior. Okay, so let's think about what this means, this emotion dysregulation disorder. What that means is that we understand maladaptive behaviors, things like self-injury, substance abuse, dissociation, as primarily functioning to regulate emotion. And in fact, that's what the data tell us, that when someone self-injures, they usually are reporting enormous amounts of aversive tension, high negative emotional arousal, and then after self-injuring feel some relief. So in other words, that behavior, self-injury or drinking or drug use or other kinds of dysfunctional behaviors actually have a function. Okay, they actually work in a very limited way. Some other things like loneliness and so forth are more a consequence of being chronically dysregulated. So we understand that BPD is a disorder of emotion dysregulation. It's not that emotion dysregulation is the symptom. It is the disorder. So here's the model. Now, I was actually going to explain this model with a different example, but I'm going to use Frank's example because I liked it, and that'll actually help to highlight some similarities and differences. So the idea, this is both a developmental model, but also a model at any given moment. And the idea is that we're flipping around this kind of stuff all the time, second by second throughout our day. So the event in the middle here that we start with, this idea of an event here, an event is not a big thing most of the time. It's not like a car crash or somebody breaking up with you or losing a job. It's an event like waiting for your therapist and having your therapist be 3 minutes late. Okay, or waiting for your partner or your date or your friend and they're 3 minutes late. Now that event elicits a certain amount of arousal just as a function of being an event in life. So how would you feel? How do you feel if you're waiting for your friend who's 3 minutes late? How do you feel? What's the normative? That's not a trick question. Yeah, you're concerned. You might be a little worried if this isn't the norm, and you might be a little disappointed because you got something you want to do, and you're disappointed that you're losing that time. And so, in fact, so that creates a certain amount of arousal. Now, arousal is normal, a certain amount of emotional arousal. Now, what also affects how much arousal you have is how vulnerable you are, both temperamentally, right? How sensitive and reactive you are to things that have an emotional quality to them in the world, but also today. Did I have enough sleep last night? Did I have enough to eat this morning? Did I compensate for not having breakfast by having 2 quad espressos? I mean, there are a bunch of things that affect our vulnerability to reacting to certain situations. So the combination of how vulnerable we are and how big the event is determines how aroused we are. Now, if we got a lot of vulnerability, which of course we would assume that people with borderline personality disorder have. There's good data about this, where they tend to be more sensitive and more reactive than ordinary folks, although we all have vulnerabilities, okay? Then the combination of the vulnerability plus the event may lead to more arousal than maybe somebody else. Now that arousal, if it hits a certain point, we start to say it's dysregulated arousal. That means that we start turning our attention to escaping the aversive quality of the emotion instead of just having the arousal, right? So it's kind of like, you know, most of us, if our friend is 3 minutes late, or even our therapist is 3 minutes late, it's tolerable. We just notice it and we continue going about our business. But if it were really a really aversive experience, like maybe you're waiting for your child and the last time your child was late is because your child had just taken an overdose. And so it reminds you of that. And so what you're doing is you're actually calling your child at that 3-minute mark because of history, actually that event has more emotional quality to it than it might for somebody else. Well, then your arousal is a lot higher after even 3 minutes with that particular person in that situation. And so then what happens, though, is that arousal, once we get dysregulated, our expression of that arousal becomes less and less accurate. So instead of saying, so then the person shows up, the ordinary, regulated person says, oh, I'm so glad to see you. whew, they breathe a sigh of relief. The disappointment's now over. The worry is gone. You're not bleeding. You're just standing there 3 minutes late. Oh, sorry. And you move on. But a dysregulated person says things like, why the hell were you late? Or, I'm out of here, and runs away. Okay, escapes the situation because the situation plus their vulnerability is creating an absolutely intolerable amount of negative emotion. Okay? So, and of course, once their expression isn't accurate, it's extremely difficult to validate it. Now, I want to point out that Frank did a lot of very validating things. Okay? I'm not actually suggesting that he was invalidating. Although, from a DBT perspective, he didn't validate the core thing. He didn't say, of course you'd be worried or disappointed. I was late. You might have said that at a later point. I suspect you did. But you attended the fact, you tried to block and so forth. You did a lot of very therapeutic DBT things too, by the way. But the situation, I think you understood it completely to this point very differently than we would in DBT. We would understand her reaction as completely normative in the beginning, and it went south. So in DBT, we understand emotion dysregulation disorders, BPD, as just more, maybe a lot more of what we all do sometimes. Right? Anybody here ever said anything mean to somebody you love? Now be honest. And how many have? New Yorkers are not the most honest people in the world. Okay. Well, that was a dysregulated moment. When you said something mean to somebody you loved, you probably were expressing some anger when in fact you were feeling disappointed. Does that sound vaguely familiar? Sounds like a dysregulated moment to me. So in DBT, and of course your response was, oh, honey, I love you too. I'm sure that's what the person said, right? No, they invalidated your disappointment because you were attacking. So, and of course that creates pervasive invalidation, at least with that person, which increases reactivity and sensitivity. So that's how we understand this disorder, as just a much more extreme version, much more chronic version of what we all do sometimes. Now, in DBT, we also have targets. And in DBT, we start with the real out-of-control stuff like safety-related behaviors and stability-related behaviors before we move on to treating problems of misery and despair and so forth. And this line here divides them. These are more ordinary problems of living. These are clinical stages, stages 1 and 2. And stages 3 and 4 are just life stages that we all go through. DBT specifically was designed to treat people in stage 1 and then move on to stage 2 and then on to stage 3. By stage 3, people are usually moving out of treatment and on with their lives. There's a lot of misconceptions about DBT, that DBT stops after stage 1. That's not true. Our studies often stop after a year, and only about half of our patients make it to stage 2 or to stage 3 within that year. So, but it's not true that we would stop treatment at the end of stage 1. In fact, we're quite content to move on to stage 2 and continue to do that. Now let's talk about Jane, this case that you've got. So let's think about Jane's targets. From a DBT perspective, we would organize them this way. Jane has self-harm. She has both suicidal self-harm, she's made some intentional suicide attempts, as well as some non-suicidal self-harm, self-injury in terms of cutting, and her paracetamol abuse, which is essentially acetaminophen, same thing. And so we would be addressing her self-harm first because that's a safety issue. The point of DBT isn't to keep people alive, but it's very hard to do treatment with people who are dead. So we kind of have to address this first. We also noticed in the write-up there was a little bit of an allusion to her having problems in treatment, that she had dropped out of some treatment, she was unhappy with some treatment, actually had frustrated some staff in a prior inpatient treatment. So we have to look at those because, in fact, if somebody drops out of treatment, it's hard for treatment to be helpful for them. So we have to work on keeping her in treatment. And, in fact, DBT is very good at keeping people in treatment with dropout rates of less than 20% over a long period, which are half to one-third what happens in community treatments. Then we would look at, and I put them as 3A, B, and C because I'm not sure what the order would be, but she's got 3 other primary targets based on the case. She's got fairly severe depression, specifically lethargy, depressed mood, and a fair amount of hopelessness, but also severe relationship problems, both the lack of good relationships and the presence of fairly dysfunctional relationships, and she's unemployed, which we think is important because in order to have a rich, satisfying life, most of us have to have something to do with our time that's meaningful to us. So we would be targeting all of these things in treatment in this order. So when she's not self-harming, we can look at treatment problems, and if the treatment problems aren't present, we would then look at these sets of issues. When these all got resolved, then we would move on to stage 2 and simply look at her issues of despair and sadness and other kinds of emotions in her life. So our secondary targets, and that's another level of analysis, include her emotional reactivity, lots of anger, shame, and other secondary emotions, and I'll come back to that concept in a minute. Lots of judgments and self-invalidation in this case, active passivity. She spends a lot of energy getting other people to solve her problems for her. Lots of emotion inhibition, specifically grieving, lots of sadness in her life that she doesn't seem to be able to express in a healthy way, and lots of inaccurate expression, her inability to describe her primary emotions. She's stuck going back and forth between shame and anger. So those would be targets for us in DBT. Now, in DBT, we have a bunch of different things we're trying to do. This is a busy slide, I apologize, but I just want to highlight that in DBT, we're trying to teach people skills. We're actually trying to enhance their capabilities. We typically do that in skill training groups. We're actually working on patient motivation to use new, skillful alternatives. That usually happens in individual therapy. We also want to generalize the skills that people use to their real life, daily life. And we do this by lots of planning and practice in our individual sessions, but also occasional between-session coaching. There are a variety of ways that can happen. But an integral part of DBT also includes enhancing our own abilities and motivations to treat effectively. So we have ongoing consultation from our DBT colleagues to enhance our skills and to keep us motivated to do our very best job. And then finally, we also have to pay attention to the social and family and treatment environment to make sure that the environment both doesn't interfere with treatment, but in fact, hopefully promotes good treatment outcomes. And in Jane's case, we're going to look at some family interventions there. So Jane's going to get, if she's going to come to DBT, she's going to get all 5 parts of treatment. She's going to go to skill training group and learn about mindfulness and emotion regulation, learn how to tolerate distress, and learn some interpersonal skills and what other skills she might need. The purpose of skill building is, of course, to empower her to replace these very small, very subtle, dysfunctional things that she's doing dozens and dozens of times a day with skillful alternatives, the kinds of things that people who aren't chronically dysregulated are doing dozens and dozens and dozens of times a day rather automatically. If Jane's DBT treatment is successful, by the end of treatment, she's not seeing these things as skills either. She's just putting her foot on the clutch when she needs to downshift as well. It's just that the clutch she's putting her foot on now has to do with her emotions. An example of this would be mindfulness skills, and this is Thich Nhat Hanh who wrote the seminal book on this called The Miracle of Mindfulness about 30 years ago. DBT mindfulness skills are based on some of his work, but specifically the psychological components of mindfulness, which include things like attention focus and not being judgmental, being able to observe and describe things, which is really important from an emotional standpoint. If Frank's patient were in DBT, she might have noticed she was a little worried what happened to Frank, okay, or I'm disappointed he's a little late, and might have been able to describe that to him, and she might have said, gee, you're late, I was worried about you, at which point he would have been incredibly validating and said, oh, God, I'm sorry I'm late, which would have soothed her, and they would have moved on. But she didn't have these skills. She wasn't able to. She ran from her primary emotions to secondary emotions. Jane's treatment also, of course, would include individual sessions to address her motivation. Specifically, in these sessions, we would look at chains. Chains are ways of inductively understanding behavior. And this is an example of a generic chain. There's some vulnerabilities, there's some event that happens, and then there's reactions. There's usually a primary emotion, some judgments or some self-invalidation, other ways of thinking about things, others maybe secondary emotions, then some problem behavior which works in some way. So while we're doing this chain and trying to understand how Jane ends up self-harming, okay, or ends up staying in bed all day instead of looking for a job, we're also validating her experience. In particular, we're validating the valid parts of her experience. We're especially going to validate her primary emotions. We're only going to validate things in the way that they're valid. We're not going to validate invalid things. Okay? You have to say this really fast. Validate the valid, invalidate the invalid. Don't invalidate the valid and don't validate the invalid. Okay? And when you do that, then we give you the sticker that says you're a therapist. Validation, of course, has to do with communicating the legitimacy of a person's experience in the way that it's legitimate. In other words, that the person's experience, their thoughts, emotions, desires, make sense in some ways. So there are multiple ways to validate verbally and behaviorally, and at the same time treat the person as an equal human being. We are also in a role, we're a therapist, so we're in a different role, but we're trying to empower the person by not exacerbating those role differences, but actually sometimes by minimizing those differences. So the idea is, of course, that when we validate, we lower the person's emotional arousal, which makes it easier for them to express accurately, which makes it easier to validate. Now, we know this from a variety of things, just your own personal experience is enough, but of course we had to do a study to show it. So a recent study by one of my doctoral students, Chad Schenk, and I, we got people very stressed. We gave them some impossible tasks to do. This is one of those classic psychology experiments, right? And when they got really stressed, we had them wired psychophysiological measures as well as getting their self-reports of their emotional arousal. Once they got up here, they were randomly assigned to either get validated or invalidated. They didn't know this, of course. And at the peak of their arousal, the experimenter either validated, and look what happens to their arousal over time. Now, the validation occurs in 30 seconds right here, okay? If they were validated, their arousal came down over time. Here, there's about another stressful thing about to happen, so it didn't come all the way down. Here, there's 20, 30 seconds of invalidation, and look what happens. Their arousal actually briefly goes up and then doesn't ever modulate, doesn't come down. So actually, the importance of validation and invalidation, I don't think can be stressed too much. So in the case of Jane, I made this chain up because we didn't have enough detail to be sure, but this would be a really typical thing we might expect to see. I'm sure there'd be more details if we had Jane here. We could talk to her. We'd learn more details, but it would be something like this. She's got some vulnerabilities. She's lonely. We know that. She might be tired. We know she's depressed. She's not sleeping well. And we know that she's reactive. We get that from the case. Then there's a trigger. Say somebody is invalidating socially. That's probably a parent, in this case, her mother, because she's got a fairly conflictual relationship with her mother. But it could be somebody else, or it could be something, another situation. It could be a lot of things. And then there's an emotion that's in response to being invalidated. Probably sadness, disappointment, okay? That's the primary emotion to being criticized, not understood. But then what happens is we know from the case that Jane is very judgmental of herself, very self-invalidating. And so she says things to herself like, I'm worthless, I'm no good, I should have done that different, I'm a jerk, I'm a bad person. Probably some expletives thrown in there for good measure. Then, of course, that creates a whole different emotional experience. Her arousal shoots up and actually creates another emotion, shame. When you're judgmental of yourself, you create shame. That's just a basic emotion fact. If you're judgmental of other people, you get angry. That's just a basic emotion fact. Of course, her reactivity means that that shame goes up so high, it's experienced as incredibly aversive, at which point she cuts herself and gets some relief. Now, of course, in the long term, this relief, even though it's relief, she's also cutting herself to get relief and actually telling her brain that she can't manage without cutting. So that actually has this long-term feedback of increasing her vulnerability. It means she's not learning to modulate her emotion. She's actually got more dysregulation down the road, not less. That's why people who cut don't just stop cutting spontaneously. Now, I've been alluding to this issue of primary and secondary emotions. It's very important in DBT. The idea is that we have primary emotions, which are the adaptive initial responses. They're universal. You go any place on the planet, and you ask a child or an adult, and you say, okay, your favorite toy, just got broken. Well, how do you feel? Everybody says sad. That's just true. Somebody's, you're in a dangerous situation. Everybody says fear. I mean, this is just true anywhere on the planet. There are basic primary emotions. And, of course, there are secondary emotions. This work is nicely done by Les Greenberg and others, and showing us that emotional responses that are secondary are emotions in response to emotion. So if I feel sad, but then I react to my sadness, that's a secondary emotion. Or maybe I get judgmental about my primary emotion or about whatever it was that created my primary emotion. So Frank's a few minutes late. I get judgmental of Frank, say what a jerk he is. Then I'm going to be angry at Frank. If I say, gosh, I'm a bad person, he probably doesn't like me, then I'm going to feel ashamed. Okay, so depending on the judgments, I end up in a different secondary emotion. In DBT, our goal is to treat the primary emotions. We actually spend a lot of time ignoring secondary emotions. This is a key difference, I think, between DBT and TFP, because I think in TFP, you see the anger and you run with it. In DBT, we see the anger and we ignore it. Now, we don't always ignore it. We help people let go of it, but we bring it back to the primary emotion. We look for what emotion's being missed in the shadow of this enormous amount of anger. Now, of course, in DBT, I also think sometimes that TFP is a product of being in New York. And no offense to you, because you're all New Yorkers, but I'm from Boston, so I'm enjoying the World Series. And World Series, oh no, that's not till Wednesday, sorry. But, my 5-year-old, the other day, actually this happened, my 5-year-old, we were walking along, and there's somebody with a Yankees hat, and he started going, literally, he went, okay? And I said to him, I said, Carlos, you know that Yankees fans are people too. And he said, oh, I know. I was just having fun. So Frank is right. People do have a certain amount of aggression, but he also, I think he's got some integration at 5, right? I mean, he's able to do that. Yeah, okay, that's good. I feel better now already. That was just my little consult. Thanks. Yeah, I know, I'm in the wrong place to be doing this. I'm sorry. Anyway, moving right along here. So we spend a lot of time focusing on primary emotions like joy and sadness. But we also don't just validate the valid emotions. We also try to change invalid emotions. Well, what we really mean are that reactions to emotions. We have an inductive understanding for this, and then we create solutions. How to do things differently using skills. And then we use behavior therapy principles from the laboratory, things like how to change the properties of stimuli and how to use different consequences to shape, all kinds of things, to actually, along with lots of acceptance and validation of the valid things, in order to get people to actually use these things in their daily life. So in Jane's case, the old chain, which we saw a minute ago, we try to break that someplace. Doesn't have to be here. It could be here. It could be here. But we'd break the chain here, and instead of, remember this was, she's got some sadness. She's got some disappointment in response to being invalidated. We would want her to observe and describe. Use mindfulness to become aware of her emotion, her sadness. Actually use an emotion regulation skill to allow herself to experience that. We call that emotion regulation skill number 9. We have like dozens of these things. Okay? And then actually do some self-soothing, because that would be an unpleasant experience, but she's not dysregulated. And self-validate. Gee, it makes sense that I feel this given what just happened. And then actually reactivate. Okay, now what am I doing in my life? Oh yeah, I've got other things to do, not just stew in this reaction. I'm going to move on with my life. I'm going to go read the newspaper. I'm going to go take a shower. I'm going to go for a walk. I'm going to go get a job. And then actually notice she feels relief here too. She's not dysregulated at the end of this chain, but she doesn't have a feedback to increase her vulnerability like there is here. If she cuts to get relief, there's feedback. It makes her more vulnerable. She does all these things. She's just left having actually a decent day. So we also work on generalization. Generalization would mean that on that chain, if Jane starts down this chain and she gets stuck and she starts going back towards the other chain, she actually could call somebody for a little coaching. She might have so much sadness that it interferes with her ability to remember some of these other things. So she actually could call her therapist or someone else in a DBT center and actually have that person say, oh gosh, that sounds like this happened. What other skills can you use? What's in your plan? And actually just remind her of her skills to get her moving down this path. There is this D in DBT, the core dialectic, which I really don't have time to explain, but it really does mean that we're synthesizing the acceptance of the person's experience while simultaneously trying to change their experience. Yes, we accept that she might be ashamed, and we're trying to change that and bring her back to sadness. We'd also include, of course, a consultation team. Everybody treating Jane would be sitting on a consultation team so that each week we could talk with each other about, not a little bit about Jane, but more about our reactions to Jane, how it is treating Jane. Do we have all the skills that we need to help her, and are we motivated? If Jane's really sullen and quiet and not very responsive, we might come into our team and be kind of demoralized. We need our team to help us know what to do with Jane if she's next week sullen and not very responsive, to give us more skills to help her get unstuck, but also to keep us motivated to do that, to increase both our competence to treat, but also our motivation to treat. And given Jane's situation, with the little bit that we know about her family, we're probably going to do some kind of family intervention. There are lots of different ways to do this. Multifamily groups are a common way. Family therapy is another way. And family connections, which you've heard a little bit about, is another way. The main targets here, of course, have to do with decreasing invalidation from her family members, which, of course, Jane could probably do some things to reduce that, like be more accurate in her expression. But meanwhile, family members hopefully are going to start looking for things to validate that are valid so that we aren't only doing invalidating things. And we're going to work on reactivating those relationships. So the challenge is to continue to integrate and synthesize all these data that come in at an idiographic level with data that come in from studies, from science, about emotion, about behavior, and to continue to create and maintain a coherent theory that is responsive to relevant data, that actually does evolve. It's not kind of a static, stuck in 1987 kind of treatment. And I have to say also that there's a lot of evidence that this approach is working. Now more than 50 studies of DBT, about 20 of which are controlled studies, with a whole range of people, adults and kids and older folks in different settings, most of whom have pretty severe and refractory problems. Most of these studies are with people with either borderline personality disorder or significant borderline personality disorder features. And the outcomes are very consistent across multiple studies. Very consistent in terms of DBT being effective at reducing suicide attempts and self-injury that's not suicidal, aggression, and a whole range of dangerous behaviors, but also decreasing substance abuse, eating disorders, anger, depression, PTSD, family problems. Dropout from treatment is quite low in DBT, and relapse is, we don't have enough long-term data, really long-term data, but the couple of studies that have followed people out several years have shown pretty low relapse rates. And importantly, also, because it's a complicated treatment with lots of parts, DBT actually costs half as much as not doing DBT. Why? Because it gets people better. And so people aren't going to the emergency room and aren't going into hospital and so forth. So even though DBT itself is a fairly expensive outpatient treatment in some sense, it's actually cheaper than not doing it because it has better outcomes. So there's some references in the slides if you're interested, and I will stop there. So.